morning, everyone. Yes, hi, Lee. Okay, good morning, everyone, and my fellow colleagues. My name is Claire, and from the Department of Social and Preventive Medicine. And it's my pleasure to introduce you Professor Lian Li, who actually joined us today from the City University of Hong Kong. And she's actually currently visiting us in the department. And please do feel free to drop by if you like to actually talk to her or talk about some possible collaboration. Just a short intro about Prof. Lee. Prof. Lee is basically she's an assistant professor in the Department of Data Science, and she has a joint appointment in the Department of Infectious Disease and Public Health in her university. Her work actually revolve around AI, big data, and also recently she has actually embarked in digital therapeutics, particularly in mental and cognitive health. And you can see from her work later that she uses an impressive range of data sources for her work, which include like social media, satellite imagery, electronic health records, biobanks, and large cohort studies. She has a very interesting background. She has a rich academic background. Basically, she earned her bachelor degree from Tsinghua University and her doctorate actually from Harvard University. She also have a few prestigious fellowship from in her back, which include, to name a few, is the Melvin First Fellowship and also the Jack Mayer University Fellowship. We are very delighted to have her with us today, this morning, and we look forward to hearing her insight. Please join me in welcoming Prof. Lee.
Okay, so good morning, everyone. So very honored. Thank you very much for Professor Claire's introduction. So I'm very honored to be here today to talk about some of my ongoing research. As just mentioned, so I am visiting this week, and I'm very interested in establishing some collaboration if there is also some mutual interest. So here is, yeah, and if you would like to stop by, and also I have my email address at the end of the presentation. So if you have any questions or you want to reach out, please feel free. So today, the title of my talk is AI for Health, Management, Treatment, and Personalized Care. This is a very short introduction about myself. So actually, my training is in public health, but after graduation, I started to work in a data science company for a few years, and I joined the Department of Data Science at City University of Hong Kong. So right now, I actually use a lot of AI or like data-driven approaches to cover a wide range of the topics related to management of health, treatment of the health, as well as some like personalized intervention in mental health related areas. So here are three of my main research directions. So one of the directions I'm working on is I do a lot of health big data analytics. So I use different kind of sources of data. So for example, we use like biobank data. We also use longitudinal cohort studies. So for example, one of the data set I use is like the global aging data, so which covers like aging populations health in a longitudinal way, including like US, China, like Europe, also like Malaysia, etc. So we are trying to understand like what are some of the risk factors of certain disease and if there is some common patterns that we can compare and analyze. I also use a lot of hospital claims and EHR data. So for example, we work on, for example, the ICU data to understand what are some of the risk factors, if we can do better risk stratifications so that we can better to allocate our healthcare resources, etc. My second major like research directions is related to health services research, which is mainly related to health economics and outcomes research. So for example, like we look at, for example, if we have certain health policy change, what are some of the consequently like behavior change from patient's perspective as well as physician's perspective. So for example, earlier we look at, for example, if we can increase like the reimbursement bar for like the primary care, so the patients probably will be more willing to go to the primary care first, then go to the tertiary hospital. And we also compare different behavior pattern between physicians. For example, like across female physician versus male physician. Also, for example, like certain like specialty, so that we can understand what are some of the implication of the policy change. We also do some like ranking per se. So for example, because we have a very strong risk stratification model, so that it helps us to understand, for example, what hospital are doing well, for example, in terms of the health outcomes, as well as in terms of the economic perspective. The quick example is that, for example, some better hospitals, they probably will have a higher mortality rate, right? But it doesn't mean that these hospitals are not doing well. It might be because the hospital is very good, so a lot of sicker patients is going to go to that hospital. So that with the risk stratification model in place, we are able to do the adjustment and do a fair comparison across different hospital and different healthcare provider. And the last research direction I'm working on is more related to wearable device. So we do like algorithm development. So because we know like wearable device, for example, like the EEG and the EDA, they probably will generate like the signal every few seconds. So it will result in a large amount of the longitudinal data. So our group is doing a lot of algorithm development so that we can understand how we can tackle this complex like data set. And right now, we also come up with a lot of intervention strategy, so mainly related to the virtual reality. So for example, we developed, for example, some like natural environment for different patients. So for example, some patients with some cognitive decline or some mental health issue, or just like people with some like a mild depression. So we established these intervention strategies and with both subjective assessment and objective assessment to understand what are some of the benefits that can generate from this VR intervention. So that's a brief introduction about my research directions. So since I only have 20 to 25 minutes today, so I'm just going to select a few ongoing projects. Just briefly to introduce them. And I think these are all very related to like public health and also clinical practice. So I do hope like if there's any interest, like we can collaborate. So the first project I want to introduce is about risk stratification and resource optimization. So the general background is, I think we all know, like in clinical practice, risk stratification is very important. So it can help us to understand like the disease progression, help us understand what's like the patient current stage, and also help us to do better effective like healthcare resource allocation, as well how to communicate with patients and their family members. However, like right now, of course, there are some like clinical experience-based like risk stratification models. So for example, like Charlson Comorbidity Index for like 1 year mortality prediction. And for example, in ICU, we have SOFA, which is also a very commonly used like a scoring like index for us to understand like the risk status. However, like these index are useful, but in terms of like the performance, it is still not very good. So if we look at like the AUC or like other like performance index, these models are still can be like further improved. So one of the piece of like our ongoing work is that we try to use advanced statistical model. So here is that we have the knockoff framework, as well as we want to take advantage of the machine learning model so that we are able to combine these two like advanced methods so that we can first to have a very strong like high performance model for us to understand what are the relative like performance for certain patients in different therapeutic areas. The second one is not instead of like a purely like machine learning model, because usually for the machine learning model, the performance is very good, but usually it is more like a black box. However, in clinical practice, like the interpretation is very important. So we want to know like what are some of the variables that we want to understand so that we still apply this knockoff filter so that we can keep a very high performance as well as have the variable selection part so that we can understand how the model makes this decision. So without going too much of the details, so here are the performance. So here we use both the simulation results as well as a few like real world EHR data to to test our performance. So in general, you can see our model is doing very well in terms of like the health outcomes that we are interested. And we are also being able to identify some of the key features. So we sorted them by the importance score so that we can understand for different therapeutic area, what are some of the key features that would be of interest. And based upon it, as I mentioned, we are also able to, because we have very strong like risk stratification baseline, so that we are able to do the provider ranking. So the y-axis is the economic part, so like how much money is going to cost, and the x-axis is that outcome, so that we can assess like the provider from two perspectives. So one is the health outcome perspective, the second one is economic perspective. So I believe this work can be expanded to many different areas, so across different therapeutic areas and across different like clinical settings. So I do hope like if you have any related like work, maybe you can also try our models and we can have a discussion. The second project I want to briefly introduce today is one of the aging and biological age project. So the general background is that nowadays more and more people start to talk about the term of the biological age. Because while people may add the same like actual age, people are aging at a different pace. So more people feel like the biological age is a more accurate reflection of like individual's health status. So in this work is that we try to use different like clinical biomarkers and image-based biomarkers and molecular and cellular like test to build a very comprehensive and accurate biological age model. So for example, a quick introduction about how we calculate the biological age. So usually there are three inputs that we can use to calculate the biological age. So the first one, it can be an image-based aging biomarker. So for example, we can use MRI image, ECG image to calculate the biological age. The second part is we can also use the clinical measured like biomarker. And third is we use molecular and cellular test. This work is that we actually use all of them and we tease out all of them, all the biomarkers to establish models for the brain information. So the input is the MRI image, output is a, so this is that we use to train the model. And this model performance, as you can see on the x-axis is their chronological age, and on the y-axis is the predicted age. You can see like in general, they are in a very good like relationship. And the R square is 0.9 and the MAE is 2.68 years. which means that we are able to only use the MRI. So like the input is just an MRI image. We are able to know like how old the patient is. And similarly, we also calculate different or other different organ age. So for example, we calculate the body age, then the heart age, like the renal age, like the immune age, cardiovascular age, etc. So while their performance can have some variation, but in general, like they are in a very good performance. So that we are working closely with a lot of like annual physical centers. We want to use this information for them to help like their patients to understand like what their clinical status, so that before like they actually develop any disease, we can have better information about these like pre-disease status, so that we can do better health management. So one last piece that I want to just briefly mention is that this work is we also work closely with like a Stanford professor. So we want to also understand the aging process a bit, because probably you may know like there is a quite famous like popular like article in the past few years is that people feel like uh, uh, people do not age in a linear way. So it might be some certain point that people will suddenly go like older, so that we want to understand what are some of the cutoff points. So one of the early reference papers saying like there are three like key year point. So at like age 36, at age 60, and at age 78. So it will have a like jump of a lot of like biomarkers. So the last piece that we are working related to this topic is that we also want to understand this nonlinear dynamics, so that it can also provide some information and insights for us to better manage our body and health. The third project I want to briefly introduce is about clinical notes and a dynamic knowledge graph. So the general background of this project is we know that in the clinical practice, we have a lot of information about diagnosis, like the medication use procedure, right? These information are usually well structured, because for various reasons. So for the recording purpose, for the reimbursement purpose. However, like one piece of the information that usually are still not being fully utilized is the information from the clinical notes. But actually the clinical notes actually contains a vast amount of the information. However, the reason that usually it is not well utilized is that because the clinical notes usually are unstructured. So it is hard for a lot of like software or like algorithm to use this unstructured information. So here, what we do is that we try to use prompt engineering and the large language model to fully like utilize the clinical notes. So what we do is that we use the large language model to help us to break down the information from the clinical notes, so that we can also generate a lot of absorb and learn a lot of insights from the clinical notes, along with the literature and the structure of the knowledge graph, so that we can build a dynamic knowledge graph, so that we can understand a lot of information that contained in the clinical notes. So for example, what can be some of the side effects of certain treatment or certain like therapy, why certain patients are more likely to experience certain symptoms, or why certain drug is working for certain patients. So I believe that this part of information is also very important, so that we want to take full advantage of this language model, so that we can fully understand to utilize all the information as much as possible, so that it can help us to make better decision and contribute to the precision medicine perspective. And the last project I want to mention is that related to the wearable device. So nowadays, the general background is nowadays more and more people realize like a lot of like people are designing, like investing and building like more and more like accurate and compact wearable device, so that it can help monitor like people or patients a different kind of status. And it can first be used to monitor a lot of status, and it can also be used to come up with a lot of intervention. So with this wearable device regard, we are also doing a lot of related research projects. So one project, as I mentioned earlier, is that we want to use the virtual reality device so that we can use this information to help us to monitor a lot of status, as well as come up with like effective intervention. So here I'm just going to provide one example. So this is our experiment setup. So for example, like this is like one of the participants. So we let him to wear this VR headset. And on the VR set is the virtual scene is shown here. So for example, we are going to give him to see like a natural forest, a urban park, or like a garden, and also some of the landscape. And the session is usually last around like, for example, 10 minutes. And we also assess a lot of like physical sign using different wearable device. So here, actually, near like his head, we also assess like his brain activity, use the EEG headset. We also use the EDA, which is like a wristband here, to assess the EDA activity, which is also a reflection of the relaxation and the stress level. And we also do the blood pressure monitor and like the HR sensor, which is inside clothes to tackle to see the heart rate variability. So in general, like if we do some like comparison before and after this VR intervention, we can see that even just a few minutes of the VR like virtual intervention, we can see a very significant reduction in a lot of assessment in the participants. So for example, we see like the anxiety level decreased, like the stress level decreased, relaxation like level increased. And this part is that we do with like normal people. We also conduct these relevant experiment in a community center. So we have participants that are older adults with some mild depression that we also do some intervention and also see some significant reduction. And nowadays, we also are trying to work with some clinician so that we want to see if there is some like clinical value. So two like clinical areas that we are currently exploring is, one is that we want to do like the pre-surgery like patients, because usually like these patients are undergoing very stressful part before the surgery. So we want to use this VR technology to do the intervention. And the other area is that actually we are working with some physicians in like Alzheimer and cognitive decline area. So we can see like we want to see like if these kind of intervention can also be useful in these areas. And these two interventions in the clinical setting are still ongoing. And of course, I hope that if there is some interest, that we can also discuss some other collaboration. So basically that's all my work going to share today. So here's my email address that if you have any, yeah, of course we still have 50 minutes for the QA, but if you think of something like offline, here is my email address, and I'm very happy to connect and establish some collaboration.
Thank you, Prof. Lee, for showing us how data science can open up a new possibility for understanding aging, as well as how we can use clinical notes to understand what influence disease outcome. We actually have a few interesting questions on the chat box. So I will just read it out, a few of them. I think we still have about 5 minutes. So the first question actually came from Prof. Noran. Her question is, how does ML models that incorporate the knockoff framework improve risk stratification compared with the traditional scoring system?
Yeah, because the traditional scoring system, actually, I think there are two streams. So one stream is like purely like clinical insight driven. So for example, as I say, like SOFA or like Charlson comorbidity, it is based on a lot of experiments from the physician, right? So they say, for example, certain comorbidity is going to give a score of 1, certain comorbidity is going to score of 2. So it is not a data-driven approach. The second stream, as I said, like there is some pure like machine learning models, right? So you just input all the features. So for example, their vital sign, like their comorbidity and their medication use. And the output will be purely, for example, just like the ICU mortality or like certain disease thing. There is no like any, there like it will, you just give like all the data to the model, then let the model to learn the patterns. So what we do this is that what we have like the knockoff framework so that we are able to generate a synthetic like knockoff framework. And instead of like we just use the a machine learning model, so we also do the FDR control, so which is for the variable selection, so that we can understand which variables are truly important and contribute to the outcome like assessment. So that we are by like comparing and doing like the synthetic data set, we are able to integrate like the ML model. So like for example, the shape value and for example, the deep learning model, as well as maintain the interpretability of like our knockoff framework. So at the end, we are going to have the performance assessment, for example, like AUC and other metrics to assess the performance. And we are also able to know like by the importance score, what are some of, for example, the 10 top like predictors for the outcomes that of interest, so that we are able to have better performance as well as have the variable selection part.
Okay,
Yeah, hope
thank you.
that answer your question.
Okay, thank you. We have another couple of more questions. One is actually from Prof. David. He said that how do you actually scan medical documents, especially when some doctors have actually poor handwriting? Or how do you actually detect over doctors' handwriting?
Oh, so that part actually we didn't handle this part because all the data set that we get, it is already in a electronic format. Oh. So
Okay.
we didn't process like from handwriting to the electronical part.
Okay. He actually has another question, which are wearables monitoring devices being used for post-operation patients?
Oh, yes, yes. So for one of the project I just mentioned, maybe I go back. So for one of the projects, so as I mentioned, so this is that we want to, what we are right now doing is that we want to do some intervention. So for the pre-operative intervention, so the intervention part, so for the VR, like thing is pre-operative, but after the VR, we also want to assess some of the post-operative outcome, so that we are also going to do like the daily, for example, the EEG monitoring, so that it can also help us to understand like what are some of the information that generated from like the different intervention. So of course, like we need to be very careful about like inclusion and the exclusion criteria. So for this one is that we are doing like I think the exclusion criteria is that we are not going to do like those brain surgery patients, because if we want to ask them to wear this EEG, we want to make sure there's like it's not like related to the brain surgery. So yeah. So we still are able to, for example, assess their EEG level as well as the EDA level.
Yeah. Prof. Lee, actually, we have a few more interesting questions, but unfortunately, it's already 9 a.m. and we have to close the session. So a big thank you to both speaker, Dr. Rosaida, as well as Professor Lee. And I would like to thank all of you in the audience for your time and also your thoughtful engagement. And it's also has been a pleasure to actually have this conversation together. So and I hope that today's session can spark new ideas and collaboration, especially with Professor Lee. And for those who are actually interested to continue your conversation and discussion with her, please feel free to contact her. And she's actually with us in our department for the next few days until Friday. So please do drop by to say hi to her. So thank you very much.
Yeah, thank you very much. Yeah.
Thank you.